Let's discuss assessing runners by watching them run on a treadmill. But before we get into that, make sure you hit the subscribe button so you get notification when we drop more videos with content like this. So yesterday I had a patient come in. She's training for a 50-mile race and she's having some IT band issues, some knee issues, some foot issues, and they're all on her right leg. So she thought it would be a great idea to go see this local physical therapist that touts himself as a running expert and does gait analysis on his treadmill. So she goes in, tells him where her pain is, and he puts her on the treadmill, tapes the session, takes her off, says, okay, see this angle, blah, blah, blah. This is what your problem is, and these are the muscles that we have to work on. Now, this might sound like a good way to assess this person, because if you're not assessing their mechanics and you're just going by them pointing this hurts and this hurts and this hurts, that would be a total guess if you're trying to figure out which muscles are facilitated, which muscles are inhibited, which is causing the breakdown and the symptoms that she's complaining about. So good first step would be a gross assessment, which in her case, which would be running. So not a bad first step, but here's where the wheels fall off. If you are just watching somebody run on a treadmill or ground running, it doesn't matter. So some people would say, well, a treadmill is different gait than ground running. I would agree with that, but that's not the point of what we're talking about here. The point is you cannot watch somebody do anything and deduce from that where their inhibition is, where the weakness is. The only thing you're seeing is how they're functioning and compensating with the dysfunctions that they have. The only way you're going to get it down to the root cause and figure out which specific muscles are inhibited is to test specific muscles. That's why watching them run on a treadmill or watching your patients go through a functional screen is a good first step. It is not the most important step in the assessment or the only step in the assessment, because it doesn't tell you anything other than what their gross abilities and inabilities are. It doesn't get you to the root cause. So she went to see this specialist. He watched her run on the treadmill, gave her her exercises, which are corrective exercises, because he didn't actually get down to neuromuscular dysfunction, gave her exercises that, guess what, did not work. Why? Because he never got down to the root cause. So he took guessing and just brought it down to a different guess. So hearing somebody talk about their symptoms, they point to an area and say, this is what hurts, or my doctor said I had IT band syndrome. Going forward from there would be a 100% guess. You have absolutely no clue what's going on with that person. Putting it on the treadmill shrinks down that guess a little bit, but it doesn't get you to the root cause. So the exercises that he gave her were the wrong exercises. And even if they were the right exercises, corrective exercises don't reestablish normal neuromuscular facilitation, which is why they don't work. If just giving people exercise worked, nobody would have to see a physical therapist. All they would have to do is go to the gym and work out, and all their problems would go away. That doesn't happen. So how do I know his exercises were the wrong exercises? Because I did a gross assessment and followed that up with specific neuromuscular assessments of all of the muscles that I saw, or that stabilize the joints that she was failing with in the screen. So I didn't put her on a treadmill. I just watched her walk, do a double leg squat, do a single leg squat. It took me less than a minute. I didn't have to waste a bunch of time on a treadmill. I didn't have to charge her an exorbitant amount of money because I'm a running expert that's gonna watch you run on a treadmill. It took me less than a minute to say, okay, I see that you have difficulty controlling pronation at your foot, knee, and hip. I know what controls pronation, so let me put you on the table and break you down muscle by muscle to figure out which one of those muscles are inhibited, which is why you can't control pronation. So once we did that, I asked her in her eval, what muscles or what exercises did he give you? She told me. When I broke her down, I said, okay, this muscle is not your problem. See how you can't stop me? And she's like, yeah. See how that hurts and that reproduces your knee pain even though I'm not doing anything with your knee? She says, yeah, that is what your problem is, and that is what we have to first refacilitate, then give you reinforcement exercises, active and dynamic warm-up and cool down, because she was also foam rolling and messing around with some stretches, which she should never do. So once we figured out what the root cause was for the specific muscles that were dysfunctional in controlling her pronation, now we've got to the root cause. Now we know how to reverse that, and now we go right into exercise progression or prescription that tells us what we should be giving her exercises for. And these are not corrective exercises, they're reinforcement exercises, because we've already reestablished normal facilitation. So, got her off the table, redid her screen. Guess what? She controls pronation at the foot, at the knee, and at the hip. She has no pain. And now we say, okay, here's your exercises, here's your frequency. When we see you in I think she's coming back in 4 days, 5 days, this stuff should be a lot better than it was before. We'll continue to clean things up and progress your exercises, because now you're going to get better. We're going to have to progress your exercise instead of just saying, go do these exercises for the rest of your life. And that is what it should look like when you evaluate everybody, especially in this case, a long distance ultra marathon runner. So once again, watching somebody move does not tell you anything except that they're failing the eyeball test. And the eyeball test does not hold up when it's time to go into treatment, which is why you have to get down to neuromuscular physiology, assessing each muscle by itself, and know that should not take forever. So just to give you an idea, from the time that she walked in the office and we took off her shoes to start her evaluation and her functional screen, to the time that I got done writing all her exercises down, ran her through the post screen, did her patient education, was about a half an hour, maybe 25 minutes. That's all the time it should take. Quit making physical therapy so hard. Quit skipping steps and guessing. When you're ready to stop guessing and get down to the root cause and use neuromuscular physiology to your advantage and your patient's advantage, you need to get below. Let me know that you're ready to change your career in less than 5 months, and I'll show you how to do that in the MemberShift.